Chapter 50, Concepts of Care for Patients with Liver Problems. In this chapter, we're really going to be looking over cirrhosis of the liver, as well as hepatitis. So what is cirrhosis? It's an inflammation caused by toxins or diseases that leads to degeneration and destruction of hepatocytes. The liver tissue becomes nodular and blocks bile ducts and blood flow through the liver. For post-necrotic cirrhosis, this is caused by viral hepatitis C and other drugs or toxins. Alcoholic cirrhosis is caused by chronic alcoholism, and biliary cirrhosis, aka cholestatic cirrhosis, is caused by biliary obstruction or an autoimmune disease. Cirrhosis slowly until it progresses to end-stage liver disease. Patient may have no symptoms until serious complications occur. The leading cause of cirrhosis in the United States is hepatitis C, and this is going to be a blood-borne illness. Hepatitis B and D are the most common causes of cirrhosis worldwide. Chronic alcohol use, bile duct disease, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis also lead to hepatitis. The inflammation caused by hepatitis C leads to scarring of the liver. It may take decades to develop cirrhosis, but hepatitis C infection with alcohol use can speed up the process. Hepatitis B, that's B as in Bravo, causes inflammation and low-grade damage over decades leading to cirrhosis. Hepatitis D, and that's D as in Delta, can infect the liver, but only in those patients who also have Hep B, and that's just because hepatitis B has to be present for hepatitis D to be present and thrive. Alcohol has a direct toxic effect on the hepatocytes, causing inflammation. If alcohol is withheld, it is reversible. If it continues, widespread scarring and cellular necrosis occurs. Similar effects are seen with cocaine and other illicit drug use. When assessing liver disease, collect information regarding age, gender, employment history, exposure to drugs or alcohol, use of herbal supplements, and chemical toxin exposure. Also look at sexual history and orientation, any needle stick injuries, family history of alcoholism or liver disease, tattoos and where they were obtained, and if the patient has been in military or prison and any of their past medical history. For a physical assessment, if liver issues are caught early, it's usually because a routine assessment is done and the early signs are nonspecific. These signs and symptoms include fatigue, weight changes, GI symptoms, and abdominal pain or liver tenderness. In compensated cirrhosis, this is going to occur when the liver is scarred but still able to function properly. These patients may have no symptoms and only display signs during routine lab work. In advanced cirrhosis, aka end-stage liver failure, patients will have late signs such as GI bleeding, jaundice, ascites, and spontaneous bruising. Box 50.3 on page 1222 details features of late-stage cirrhosis. For our abdominal assessment, we are going to check for ascites. This is excessive fluid in the abdominal cavity, and we are going to measure their abdominal girth. A rapid increase in body weight is the most reliable indicator of fluid retention. The belly button may stick out, and the patient may have dilated abdominal veins. For our complications from ascites, orthopnea, dyspnea, difficulty standing up straight, difficulty balancing, and an inguinal or umbilical hernia may occur. As for hepatomegaly, this is liver enlargement, which occurs in early cirrhosis. In advanced cirrhosis, the liver shrinks and develops nodules. And assess for splenomegaly, which occurs for cirrhosis patients who have non-alcoholic cirrhosis. For other physical assessments, assess for blood in the vomit or stool. Determine if the patient has a fruity or musty odor, which is consistent with chronic liver disease, and hepatic encephalopathy. Amenorrhea in women, gynecomastia, testicular atrophy, and impotence in men are also common. For our neuro assessments, continually assess neurologic function and, if necessary, obtain baseline from family members. Monitor for asterixis. This is coarse tremors with rapid, non-rhythmic extensions, as well as flexion in the wrists and fingers. These are going to look like hand flapping. These are signs of hepatic encephalopathy. And then for our psych assessment, we are going to assess for subtle, obvious changes in cognition, personality, and behavior. We are going to assess for sleep disturbances, for emotional lability. We are going to assess for substance abuse that may continue or worsen as a coping mechanism with this disease. We also want to determine the dependency on alcohol and assess or prepare for withdrawals. Signs and symptoms include tremors, neuro changes with delirium, confusion, anxiety, psychotic behaviors, and these can include delusions and hallucinations. The picture on the left shows dilated abdominal veins seen with massive ascites and late cirrhosis. The picture on the right shows a protruding umbilicus due to massive ascites. Table 50.1 on page 1223 details abnormal lab findings associated with liver disease and their significance. All the liver enzymes will be elevated. These include AST, ALT, and LDH. These enzymes are released in response to liver inflammation. However, as the liver worsens, it may not be able to mount an inflammatory response, meaning that these levels could be normal. We are also going to look for a prolonged PT and INR. The liver decreases production and reduces production of prothrombin, leading to low platelets, low red blood cells, low H&H, and white blood cells. Prolonged PT and INR can cause bleeding problems. For our imaging, we can use X-rays to diagnose hepatomegaly, splenomegaly, or massive ascites. An MRI detects mass lesions and determines if the condition is malignant or benign. An ultrasound can be used to detect ascites, hepatomegaly, and splenomegaly, biliary obstructions, portal vein thrombosis, and blood flow. Liver biopsies can be used to determine pathology and extent of any disease here. Arteriography is going to be used to evaluate the portal vein by passing a catheter through the liver into the portal vein. An EGD can be used to detect upper GI complications of liver disease, such as bleeding esophageal varices, stomach irritation or ulceration, and bleeding. And lastly, we have our ERCP. And that ERCP is going to stand for endoscopic retrograde cholangiopancreatography. And that is a mouthful, so we call it an ERCP. And in this, the endoscope is going to inject contrast into the sphincter of Oddi to view biliary tracts and to provide interventions like stone removals, sphincterectomies, biopsies, and stent placements. This is just an image for liver dysfunction. The signs and symptoms are really going to vary depending on the disease progression, but if you're a visual learner, this visual is for you. You can see all the marks, the distended veins that this patient has. You can see it's kind of swollen. And you can read the signs and symptoms that are on each side of this visual. When we look at compensated versus decompensated cirrhosis complications, what we're really looking for is the presence of signs and symptoms, and that is going to determine whether or not it's compensated or decompensated. And you guys can see that on the slide here. For portal hypertension, this is the persistent increase in pressure in the portal. It's a major complication of cirrhosis caused by increased resistance to or obstruction of flow through the portal vein. In this case, the blood will meet resistance when it's traveling through the liver, so it travels to areas of least resistance, causing blood to backflow into the spleen. This causes the spleen to become enlarged, and an enlarged spleen will cause platelet destruction, causing thrombocytopenia, which is the first sign of liver dysfunction. With portal hypertension, the esophagus, stomach, rectum, intestinal, and abdominal veins become dilated. It causes ascites, esophageal varices, prominent abdominal veins, and hemorrhoids. Collection of free fluid in the abdomen. The collection of plasma proteins in the peritoneal fluid draws fluid out of the intravascular space, causing third spacing. The patient may experience hypovolemia and swelling at the same time. Massive ascites can cause the renal vasoconstriction, triggering the RAAS system. This is going to lead to sodium and water retention, and this is also going to lead to even more ascites. Our esophageal varices are going to be fragile, thin esophageal veins that distend and twist from increased pressure. Decreased PT production in cirrhosis puts patients at risk for bleeding. So ruptured varices are life-threatening and may cause hypovolemic shock, hematemesis, black and tarry stools, and loss of consciousness. For patient education, have the patient avoid activities that increase abdominal pressure. This includes heavy lifting or vigorous exercise. And the image to the right is actually showing a bleeding esophageal varices, and you guys can look over and see that. What looks like a line going straight across that black hole, that's actually blood. For our biliary obstruction, so bowel production is decreased, and this is going to cause the prevention of absorption of fat-soluble vitamins, such as vitamins A, D, E, and K. No vitamin K means not enough production of clotting factors, and that is going to put patients at a risk for bleeding and easy bruising. Jaundice is caused by hepatocellular disease or intrahepatic obstructions. Hepatocellular jaundice is caused by the liver not excreting bilirubin. Intrahepatic obstruction from edema, fibrosis, or scarring of the hepatic bile channels and bile ducts are going to interfere with bile and bilirubin excretion. Patients with both types of jaundice are going to report itching. Hepatic encephalopathy, aka portal system encephalopathy, or PSE, this is a cognitive syndrome caused by liver failure and cirrhosis. Signs and symptoms include sleep disturbance, mood disturbance, change in mental status, and speech problems. PSE may be reversible if it is caught early. Late signs include altered level of conscious, impaired thinking, and neuromuscular problems. This may develop slowly and go unnoticed until later signs develop. Box 50.1 on page 1220 details the stages of development. Factors that worsen hepatic encephalopathy include a high-protein diet, infection, hypovolemia, hypokalemia, constipation, GI bleeding, and drugs. Hepatorenal syndrome is a poor prognosis. It's often the cause of death in these patients. Signs and symptoms include a sudden decrease in urine output, usually less than 500 milliliters in 24 hours, elevated bun and creatinine, decreased urine sodium excretion, increased urine osmolality, and this also occurs from GI bleeding or hepatic encephalopathy. With a spontaneous bacterial infection, bacteria from the bowel reach the fluid from ascites through the bowel wall into the lymphatic system. Signs and symptoms include malaise, fevers, chills, pain in the abdomen, and tenderness. It may cause worsening encephalopathy and increased jaundice without abdominal symptoms. This is confirmed by a paracentesis with a culture of the fluid. And finally, we have hepatopulmonary syndrome. This is caused by excessive ascites fluid, leading to dyspnea from increased intra-abdominal pressure. For the treatment of esophageal varices, propranolol will decrease the heart rate and the hepatic venous pressure gradient, reducing the chance of bleeding. We are going to monitor vital signs for bradycardia and hypotension. In many cirrhosis patients with upper GI bleeds, the bleeding is caused by an infection. Infection is the most common indicator that the patient will have a variceal bleed. Give antibiotics to treat the infection, and it will hopefully help prevent the bleeding. When bleeding does occur, we are going to use vasoactive drugs, such as vasopressin, and this will be used to create vasoconstriction, and this will reduce the blood flow, therefore decreasing portal pressure. Octreotide acetate is also used to decrease venous pressure. It can also suppress the secretion of gastrin, serotonin, and intestinal peptides, which will decrease GI blood flow and in turn reduce the blood flow to varices. This is more commonly used because vasopressin has adverse side effects. For endo treatments, in an endoscopic variceal litigation, this can be banding the varices to decrease the blood supply to them. There is an endoscopic sclerotherapy. This is where varices are injected with sclerosing agent, causing inflammation and fibrosis. And then we have a TIPS procedure. This is a non-surgical treatment performed by a radiologist. It's used for patients not responding to other therapies. A needle is guided through the jugular vein, through the liver, and into the portal vein, and a balloon is used to enlarge it, and a stent will be placed in the portal vein to keep it open. Complications are not common, and the patients are monitored for 1 to 2 years to ensure patency. We are going to monitor for hepatic encephalopathy because blood flow now bypasses the liver's filtration system, and it can allow toxins to build up, causing changes in level of consciousness and behavior. Lactulose and other medications may be given to counteract this. Pulmonary artery pressure may significantly increase, causing increased blood flow to the right side of the heart. Because of this, diuretics are going to be used in treatment, and the patient must be checked for right-sided heart failure after a TIPS procedure. Rescue therapies are warranted if bleeding recurs, and a balloon tamponade is going to include esophageal stents and shunting. A short-term esophagogastric balloon tamponade with stents is going to occur, and a tube is placed through the nose, like with an NG tube, and it's going to go down into the stomach, and a balloon is inflated to apply pressure to bleeding varices. The patient is intubated and on a ventilator for this, and it's only used if a patient cannot have a second endoscopy or a TIPS procedure. This is like a very last resort going on here. And then depending on the procedure, the patient will have an NG tube to detect any kind of new bleeding. They'll receive packed red blood cells, fresh frozen plasma, dextran, which is a blood plasma substitute, albumin, and platelets. We are going to be monitoring APT, APTT, platelets, and the patient's INR for that bleeding. So after that super fun talk about managing esophageal varices, let's talk about the management of cirrhosis. So here we're going to be managing fluid volume by decreasing ascites and peripheral edema. Supportive measures to control ascites include nutrition, a low sodium diet to control fluid accumulation, about 1 to 2 grams a day, no table salt, and alternative flavors and seasonings. For drug therapy, we're going to look at diuretics. We are going to reduce fluid accumulation and prevent cardiac or respiratory problems with diuretics. We're going to monitor with daily weights, I's and O's, abdominal girth, peripheral edema, and electrolyte levels. Next, we have a paracentesis. So this is an invasive procedure to remove abdominal fluid. A trocar catheter or a drain is inserted into the abdomen to drain fluid off. A short-term drain may be placed while the patient waits for surgery. Box 50.4 on page 1225 gives you nursing implications for a paracentesis vital and weight before and after. You're going to have the patient empty their bladder beforehand. If the patient is ordered to be NPO, keep them NPO, and position the patient supine with the head of the bed elevated. We are going to observe and measure any fluid that the patient has as far as intake and output goes. For respiratory support, ascites can cause respiratory problems from the increased intra-abdominal pressure. Patients can develop hepatopulmonary syndrome, including dyspnea, limited thoracic expansion, and diaphragm excursion. Auscultate the lungs every 4 to 8 hours for crackles or adventurous breath sounds. For hemorrhage management, this is something that we discussed during the esophageal varices treatment. For managing confusion, so a lot of patients who have cirrhosis can become confused because they have an accumulation of ammonia. That's the big thing that comes with ascites, is going to be those ammonia levels. So the accumulation of ammonia is one of the first things that you will address to manage confusion, and managing ammonia levels will improve the mental status. For dietary modifications for managing confusion, we are going to use a moderate amount of fats, protein, and simple carbs. For drug therapy, this is a big one with ammonia levels. So we use lactulose or non-absorbable antibiotics. Lactulose is going to promote the excretion of ammonia through stool because it's got to go somewhere, so we're going to poop it out. So it's going to promote the excretion of ammonia through stool, it's going to have a laxative effect, and it's going to draw fluid into the colon, preventing the absorption of pneumonia. We decrease those ammonia levels, we decrease confusion. Our goal here is going to be 2 to 3 soft stools a day. Side effects include bloating, cramping, hypokalemia, dehydration, and skin breakdown from excessive stool, so especially if your patient's not continent. For those non-absorbable antibiotics, these are going to be given when lactulose is not helpful or tolerated by the patient. Neomycin sulfate or Lord help me, it is rifaximin, I'm sorry. So neomycin sulfate or rifaximin may be given to act as an intestinal antiseptic. This is going to destroy the normal intestinal flora and is going to prevent protein breakdown and ammonia production. Anytime we're treating those altered levels of consciousness, any loss of consciousness, anything of the sort, We're going to frequently assess these changes, and we're going to assess their orientation, and we're going to look for any signs of worsening encephalopathy. And then for managing pruritus, this is going to be that itchy feeling that our patients may get. We want to avoid the patient getting too warm. We're going to moisturize the skin. We want to avoid irritants. We can use cool compresses and corticosteroid creams. If conservative measures don't work, SSRIs may be helpful, and an example of an SSRI would be Zoloft. For care coordination and transition management for our patients who have cirrhosis, our patients may need home health referrals or discharge to a long-term care facility, especially those who are in late-stage cirrhosis. For our home adaptations, the patient may need a sleeping area and bathroom close to each other or a bedside commode. They also may need briefs for incontinence. We're going to elevate the head of their bed, or we're going to have them sleep in a recliner. We are also going to give them instructions on ascites drain management and to not drain more than 2,000 milliliters at a time. Otherwise, it can cause a rapid fluid shift and cause hypovolemic shock. For our patients' diet, we want them to have small, frequent meals. They need to avoid excess vitamins and minerals that are toxic to the liver. These include vitamin A, vitamin D, vitamin E, vitamin K, iron, and niacin. Make sure that you're teaching the family about the signs of encephalopathy and things that increase the risk of it. These include constipation, bleeding, and infection. We want the patient to avoid alcohol, smoking, illicit drugs, and all over-the-counter drugs, especially acetaminophen, NSAIDs, liver-toxic herbs, vitamins, and minerals. For these patients, we can also have them go to a substance use help group if abstinence cannot be maintained for those patients who may have alcoholic cirrhosis. The expected outcomes of effective treatment of cirrhosis, and these include having a decrease in or have no ascites, having electrolytes within normal limits, having no hemorrhage or they will be managed immediately if bleeding does occur. The patient does not develop encephalopathy or will be managed immediately if it occurs, and the patient successfully abstains from alcohol or drugs if the disease is caused by one or more of these substances. Now we are going to talk about non-alcoholic fatty liver disease, also known as NAFLD. So in NAFLD, the liver stores excess amounts of fats from the body, and it's not related to consuming alcohol. It's primarily related to obesity, high cholesterol and triglycerides, type 2 diabetes, and metabolic syndrome. Therefore, prevention is centered around a healthy lifestyle choice to decrease the risk of developing NAFLD. Genetics also play a role. People who carry a certain gene are at high risk for developing this disease. People of Latino descent have a higher rate of possessing this gene, and that's going to put them at a higher risk for NAFLD. For our signs and symptoms, patients can remain asymptomatic for years while the disease develops. Initial symptoms tend to be vague, and they can include fatigue and malaise. Specific symptoms are right upper quadrant pain and pruritus, and remember that pruritus is itching. Jaundice may also be present later on. For our diagnostics, these are similar to diagnosing cirrhosis, and like most liver diseases, AST and ALT are elevated. We can use an ultrasound and liver biopsy to gauge liver damage. Along with this, we have non-alcoholic steatohepatitis. This is also known as NASH. And NASH is a severe form of NAFLD that develops. It is characterized by hepatocyte injury, liver inflammation, and fibrosis. NASH can contribute to liver cancer, cirrhosis, or liver failure, and it can cause a premature death. 20% of patients diagnosed with NAFLD will develop NASH. Our treatment, there are currently no medications approved for treatment. Instead, the treatment focuses on lifestyle modifications aimed at weight and fat loss, like developing better nutrition, exercise, and behavioral changes. Next, we have hepatitis, and I'm sure everyone has heard of hepatitis at least once. Most of us have gotten our hepatitis B vaccine. But what is it? So hepatitis is a widespread inflammation and infection of the liver cells, and viral hepatitis is the most common and can be acute or chronic. It's less commonly caused by chemicals, drugs, and herbs, And we are going to focus on those caused by viruses, which include hepatitis A, B, C, D, and E. Our patho. So, a liver injury with inflammation can develop after exposure to toxins or as a secondary infection to viruses. After exposure, the liver is enlarged and filled with inflammatory cells, which are lymphocytes, and fluid causing right upper quadrant pain. As the disease continues, liver cells are not regenerated. Inflammation and necrosis leads to an increased portal pressure, which is going to limit the blood flow to liver loads, and it's also going to obstruct bile channels, which is going to cause obstructive jaundice. Now, the patient can have acute or chronic hepatitis. Hepatitis is chronic when liver inflammation lasts longer than 6 months. The most common causes for chronic hepatitis is hepatitis B as in boy or C as in Charlie, and chronic hepatitis can lead to cirrhosis and liver cancer. For our signs and symptoms, box 50.7 on page 1232 is going to list key features of viral hepatitis: abdominal pain, yellow sclera, muscle and joint pain, diarrhea or constipation, light clay-colored stools, dark yellow to brown urine, jaundice, fever, fatigue, malaise, anorexia, nausea and vomiting, dry skin, and pruritus can all be signs and symptoms. Now, the hepatitis C virus, that C is in Charlie, can be different from the rest of these hepatitis viruses because early hepatitis C virus displays those key features, and chronic hepatitis C virus has extrahepatic complications. So this means we might have complications that don't necessarily just affect the liver. These can include depression, polyarthritis, myalgia, renal insufficiency, cognitive impairment, and even cardiovascular issues such as vasculitis and heart disease. For our diagnostics, for our labs, hepatitis A, B, and C can cause increased AST and ALT levels. Your serologic markers can be found on page 1232 in your textbook, and a liver biopsy can be used to confirm diagnosis and grade the liver damage or any kind of liver cancer. So let's go ahead and get a little bit more specific and go over the types of hepatitis. It is pertinent that you know these and you understand them because different types of hepatitis are going to be caused by different things. So hepatitis A is caused by the enterovirus, and think of entero, think of your stomach. It survives on human hands and it's resistant to detergents and acids, but it's destroyed by bleach and high temperatures. Transmission is through the fecal-oral route from person to person, or the consumption of contaminated food or water. So think about it, hepatitis A is caused by the enterovirus. Enterovirus is going to be related to your stomach and you put food in your stomach. So it's caused by the consumption of contaminated food or water. Common sources can include shellfish because those can come from contaminated water. An illness is similar to a GI illness and patients usually recover easily. The incidence of hepatitis A is higher in countries with poor sanitation. Think poor sanitation, you may not have that clean water, so you're more likely to be exposed to hepatitis A. The vaccine for this is available and it's usually given around 12 and 18 months. We want to encourage these patients to have good hygiene and educate them on food safety in an effort to prevent hepatitis A. Moving on to hepatitis B, that's B as in boy. This is a bloodborne pathogen that's spread through many modes like needle sharing, unprotected sexual intercourse, blood transfusions before 1992, and birth from an infected mother. So these are going to be in our blood. Most patients have no symptoms and can clear the virus from their body and develop immunity, while others just become carriers. Those who are chronic carriers are at risk for cirrhosis and liver cancer. And the Hep B vaccine is given at birth, at 1 to 2 months old, and at 6 months old. If you are a healthcare worker, you are tested for immunity. I know a lot of us who do clinicals, especially those of us who do clinicals at Southwell, they want you to have hepatitis B titers drawn, even if you've had the vaccine, just to make sure that you have your antibodies so you are not at risk for contracting hepatitis B. And once again, just touching on the vaccines, you guys will also learn this in your Mother Baby Peds course. Hepatitis B is one of the very first vaccines that we give to our infants. Moving on to hepatitis C. So hepatitis C, that C is in Charlie, It's the most common bloodborne infection in the US because unlike hepatitis A and B, there is currently not a vaccine available for this. The disease is transmitted by blood-to-blood contact, and this can happen through the shared use of needles. This is actually one of the reasons that programs exist to provide clean needles. For some drug users, they can exchange their dirty needles and get clean needles at the health department. And the reason of this is actually to prevent the spread of hepatitis C and HIV to drug users. And yes, it is controversial, but at this point we are looking at prevention for an entire community because they can spread that to people who don't use the same needles as them if they have family or loved ones that they're interacting with and they have a chance of swapping blood with them. So this is something that, yes, it can be morally controversial, but we are looking at prevention for community health care here. And then patients may be asymptomatic for years and they're not diagnosed until complications develop. Chronic hepatitis C can develop leading to cirrhosis or liver cancer. Next, we have hepatitis D, that's D as in Delta, and this only occurs with hepatitis B virus because it is an incomplete virus and needs that hepatitis B virus to replicate. It's transmitted by parental routes such as the sub-Q route, IM route, and IV route, and it is also common among IV drug users. And finally, we have hepatitis E. That is spread through fecal contamination. It's common in other countries in Asia, Mexico, Central, South America. Most cases in the US are from travelers, and this disease tends to resolve on its own. Moving on to prevention for hepatitis. For hepatitis A, we recommend the vaccine, good hand hygiene, and avoiding contaminated food or water. For hepatitis B, we recommend the vaccine. We use standard precautions. You don't have to use your gown, mask, and goggles for these patients, just your standard precautions with your gloves. Testing healthcare workers is also used to help prevent the spread of Hep B, avoiding needle sticks, and vaccinating high-risk groups. For health promotion of hepatitis, we are going to promote nutrition. We want a diet high in carbohydrates and calories with moderate fats and protein added after the nausea goes away. We want the patient to consume small, frequent meals, high-calorie snacks, and supplemental vitamins as prescribed. To manage fatigue, we want the patient to rest and to reduce the metabolic demands of liver and increase the liver's blood supply. We alternate rest and activity and use medication sparingly to allow the liver to rest. Hepatitis B and hepatitis C are life-threatening, so certain drugs are used for treatment. Those drugs are listed on page 1234 on table 50.2. We are also going to educate the family on prevention. The patient should avoid alcohol and talk to their primary care provider before taking any medications or supplements. They should also avoid crowds as they are an infection risk. Moving on to liver transplantation. So this is for patients who are not responsive to conventional treatments. Those who are not eligible include those with severe cardiac disease, severe respiratory disease, metastatic tumors, or the inability to follow a treatment regimen. Remember, like we talked about with our kidney transplants, if you were put on a transplant list, you have a strict set of criteria and rules that you follow. Someone who is on a list for a liver transplant is most likely going to have that they cannot consume any type of alcohol while they are awaiting a liver transplant. If they do not follow those directions, they are removed from the list. Just because that list is very selective, they do not tolerate someone who is not going to follow those rules to be gifted a new organ. So donors for this can be deceased or living. Living donors usually just donate one lobe, and the deceased liver is removed and replaced with the donors. Common complications, as always, we have acute graft rejection, vascular or biliary obstruction, and infection. Signs and symptoms of each are listed on page 1236 on table 50.3. Take a moment to read this question. It is asking about a patient who has undergone a paracentesis today. Which assessment finding is going to alert the nurse that the procedure is successful? Take a moment to review your answer choices and you can pause your video here. We will discuss the answer on the next slide. The answer to this question is A, is it alpha? We are going to measure the patient's weight because weight should decrease as fluid is drained from the abdominal cavity. ahead and take a moment to review this question. It's asking about an assessment that reveals yellowish coloration of the skin and sclerae. Go ahead and determine which laboratory values you are going to anticipate, and we will review these on the next slide. The answer here is going to be B as in boy. Whenever a client's skin is jaundiced, laboratory values of indirect and direct bilirubin are going to be increased. So when a complete assessment of this client is performed, what other signs and symptoms are you going to expect? This is a select all that applies, so take a moment to look at your answer choices, and you can pause your video here and we will discuss the answers on the next slide. So the other signs and symptoms that we are going to see are going to be dry skin with a rash, peripheral dependent edema, and ecchymosis or spider angiomas. The answers here were B as in boy, D as in delta, and E as in echo. Personality changes and muscle twitching are findings that may be seen when the client with cirrhosis has developed portal systemic encephalopathy. Dry skin, peripheral dependent edema, and ecchymosis are signs that are associated with cirrhosis. Go ahead and take a moment to review the question here. In this scenario, the client is telling the nurse that once he's discharged home, he has no intention to stop drinking alcohol. Think about the appropriate nursing response here. You can pause your video here and we will discuss the answer to this on the next slide. The answer to this question is C as in Charlie. Asking the client about quitting allows him to express his feelings about drinking. Response A demands an answer that's not therapeutic. Remember, we're not asking those why questions. Response B does not give recognition to the problem of drinking. And response D gives an ultimatum rather than listening to whatever the client is telling you and their concerns. So we just did that case study. I know it was short. Let's go ahead and do a few multiple choice questions just to gauge to see how well you have learned what you have in this PowerPoint. Try not to use your book if you can, but if you really just don't get it and you need to use your book, that's okay. This is the time for your practice. Go ahead and take a moment to review this question. It's asking about which assessment findings require immediate nursing interventions in a client with severe ascites. Review your answer choices and select one, and I will meet you on the next slide for the answer. So the answer is going to be D as in delta. So those short, shallow, increased respirations are going to be problematic here. Think about those ABCs. Ascites can increase abdominal distension, and that is going to press up on your diaphragm, and it's going to interfere with lung expansion. It's going to compromise ventilation, oxygenation. The risk for infection, fluid displacement, and confusion are also assessment variables requiring monitoring the client with ascites, but here we are going to have to prioritize. Go ahead and take a moment to review this question. Here we are looking at what the priority nursing intervention is in the management of a client with decompensated cirrhosis. Go ahead and take a moment to review your answer choices and pick the best answer. And you can pause your video here and we will discuss the answer on the next slide. The answer to this question is going to be B as in boy. So decompensated cirrhosis has multiple complications, of which bleeding esophageal varices is one. Remember those bleeding esophageal varices, that's where we're having those blood vessels burst and they're in your throat where you have that airway. So this condition can present a life-threatening emergency. Think, you can have blood running all down your airway, it can suffocate you. Preventing nausea and vomiting is an important intervention in the management of esophageal varices. Monitoring protein, fluid balance, and client positioning are also important interventions in the care of the client with end-stage liver disease, but once again, this question is about prioritization. I know you guys have been with me for about 40 minutes and you are just, I know your brain's overloaded, so of course we had to go out with a bang and have a dietary question. So go ahead and look at your answer choices and think, which food item are we going to remove from the dietary tray of a client who has hepatic encephalopathy? So the answer here is D as in delta. And the reason is because a high protein diet can worsen hepatic encephalopathy. So we're going to remove the food that has the high protein content. So that is the end of our chapter. You guys have definitely been champs getting all the way through it. If you have any questions, please refer to your textbook. And if you still have questions, as always, please just reach out to your instructors. That is what we are here for. We would definitely love to clear anything up that you're unsure about before you take your test. Thank you and good luck.